first category we are going to look at is building reliable care. This category focuses on evidence of increasing reliability, implementation of evidence-based practice, making it easy to do the right thing and hard to do the wrong thing, and evidence of co-design and co-production and service user and carer involvement. So the finalists in this category are Enhanced Care at Home Prescribing Across Primary and Secondary Care Interface, South Eastern Trust, the Acute Medical Model, Northern Trust, Minimum Acceptance Criteria, Belfast Trust, Reforming Rapid Angina Assessment Clinic Services, HSCB. And the winner is the Acute Medical Model, Northern Trust. Congratulations, Northern Trust. We're going to take a little bit of time now to hear about the award-winning entry.
We are happy to present our Acute Medical Model as part of the HSCQI Improvement Awards under the category Building Reliable Care. Sister Julie Mann and myself, Dr. Darshan Kumar, shall take you through our presentation. The background to this was the need for an acute team focus in our hospital. Prior to this model, we didn't have an acute medical focus nor ambulatory care, and this had a direct impact on bed capacity and also on patient flow. There was the need to get the right patient in the right place and at the right time. We hence commenced this acute medical model project. This project involved a multi-professional team designing, testing, and implementing an acute medical model in Antrim Area Hospital as part of the Trust Reform and Modernizing program. There was the need to test the acute medical model that was envisioned by having visited several acute medical units across the country and taking several positive flow aspects into consideration. Towards this, our aim was to increase to 50% the number of short stay admissions, that is, admissions with 0 to 2 day length of stay by April 2020 in our hospital. We also wanted to increase the number of patients seen by a consultant within 14 hours, and this is as per the Society of Acute Medicine and Royal College of Physicians standards. We wanted to ensure that our patients receive the right care in the right place and at the right time, and towards this, our aim was to reduce the average ward moves to less than our mean. We used the IHI and QI methodologies and came up with a primary driver diagram. As you can see, our primary driver diagram might seem complex, but it was necessary as it needed lots of aspects incorporated. Towards that, we had a primary driver, secondary driver, and interventions to support and achieve our measures. One of the way we managed this was by creating several work streams. As I mentioned before, ours was a multi-professional diverse project team, and it's seen here. And our project work streams incorporated all aspects of patient journey, patient flow, and patient experience.
Indeed, I remember this well. I had been in post about a year and a half developing a new general medical ward, and we were just getting our heads above water with an RQI inspection confirming our progress. Then Darshan popped his head round my office door to discuss his vision of developing a new acute assessment area in B4. And I did laugh to myself, stating, "You're all trying to push me over the edge before I retire."
Not at all, Julie. Indeed, it was because of the staff's resilience and support that we undertook all the necessary whiteboard tests. We incorporated all the IT systems and information recording systems, and we also undertook a simulated patient journey, and thus the acute assessment area was established. Another important aspect of our project was the aspect of service users and stakeholders. We carried out a 10,000 voices survey before the project commenced. This allowed us to better understand the original medical model and incorporate feedback that would improve patient experience. We conducted a co-production engagement session with expert patients. This involved outlining draft proposals for the model, discussing these, and integrating feedback into its design. We regularly collected and acted on feedback gathered in the AAA area through surveys and feedback buckets. What we have shown here is a snippet from our ICT interfaces, which shows our promotion of the acute medical model. Here is another snippet from the 10,000 more voices action plan template. What we are trying to emphasize here is that we used all the quality improvement methodologies. We had the advice of Bevan O'Donnell, who came at the opportune moment as an IHI improvement advisor. As you can see here, our music score was 135.5, and pre-project, this gave us reassurance that there was a reasonable chance for success. We used process mapping where needed and also incorporated multiple PDSA cycles as part of the model for improvement. Our measures were divided into the outcome, process, and balancing. Our outcome measures were looking at the percentage of admissions with short stay, percentage of admissions seen by a consultant within 14 hours of their admission. The process measures was looking at the percentage of patients through AAA and also who were referred on for ambulatory care. We looked at balancing measures, which actually gave us reassurance on patient safety. This was by looking at the time for specialty patients to reach the specialty wards. We also looked at the average number of ward moves per patient, and we also looked at the readmission rates. We look at the results from the outcome measures, and this is the percentage of non-elective admissions with short stay. I want to show you that the graph starts from April 2017, but our preparations for model began at around February to April 2019. Our model was actually launched at the end of September, but we incorporated small aspects of the acute medical model right at the preparation phase. As you can see, our trend shows that we have been consistently above the mean since the preparations for the model began, and we have done very well even during COVID phase. When we look at the percentage of patients going through AAA and the time recorded as seen by a consultant within 14 hours, this actually highlighted the need for better ICT interfaces. Currently, we are undertaking this by manual audits, and we are reliant on proper recording in case notes. But again, to emphasize that we have been consistently performing above our baseline data at 45%. When we look at the percentage of suitable patients going through our acute assessment area, I think this is an important slide because this actually showed us that small changes from our baseline actually reflected as very big positive achievements in patient care data. If I can highlight to you on the winter of 2019, this was when there were considerable bed pressures, and very quickly we went on to the old model. Through the PDSA cycles, we regained control on the medical model, and once we started to increase the throughput through our acute assessment area, we noticed that our other outcome measures improved significantly. Another important slide is the percentage of patients discharged out of hospital from acute assessment area. Since the inception of model, you can see the trend of us consistently being above 20%. And this was through engaging patients in ambulatory care. If I can highlight to you the January and February of 2021, when the whole hospital or possibly in the whole region was under chock-a-block due to the COVID pandemic. Nearly 90% of our hospital discharges came from acute assessment area. When we look at our balancing measures on the percentage of readmissions, this was important to us, as since we were engaging with ambulatory care, we wanted to ensure there was no compromise in patient care or safety. As you can see here, the percentage of readmissions did not change.
And then we have our staff feedback. We created a Nichols book with daily review and support to enable staff regularly reviewing our PDSA cycles. And we did this with no additional resources in an environment that was demographically challenging as it was spread over 2 areas. Our success was due to the flexibility, collaboration, and resilience of the staff, and we got there. It was so good to see ownership and change being embedded into practice, as we all know the challenges of change management. And this was confirmed with our patient feedback, highlighting their positive experience. And this gave us the confidence that we were providing high standards of patient-centred care in Antrim Area Hospital, and that we are doing the right thing. In summary, our assessment area is meeting our new corporate objectives: better health, better care, better value, and we have saved over £1 million of the public purse. Using QI methodologies, we have built a safe and reliable model for patient care in Antrim Area Hospital. From this, the lessons learned: our success was due to collaboration, team working, innovation, and resilience. As ward sister, I feel very humbled and extremely proud, as we have created an environment where clinical excellence can flourish. I used to address the team as the A team, but now we have expanded due to our success and taken the 3 A's from our new name of acute assessment area, and we are now called the AAA team. Not that I would be biased or anything. Thank you.
Thank you very much, Julie. A special thanks, and I want to acknowledge every member of our acute medical team and the acute medical project, as without their help and support, we wouldn't have achieved this. Thank you everyone for listening.
So Darshan, I am absolutely delighted to present you with the Building Reliable Care Award. Very well done.
Thank you very much, Aidan. It's indeed a pleasure and an honour to accept this award. As we had mentioned, ours is a multi-diverse professional team, and we are all happy to accept this award. Thank you very much.